If it doesn't say estradiol on it, it's a synthetic form. And if it says estradiol, that's real estrogen. And a lot of people don't know that there's even a difference. I'm not against birth control at all, because I do think that it has given us as women this great opportunity to decide when we want to have children and our sexual health. I think that the way that we should be using it, though, is for the shortest duration possible for what's needed.
That's one of my challenges with prescription drugs is when we block natural things the body does, there's consequences.
Welcome to The Trusted Pharmacist, where you'll learn the truth about how the body works.
Welcome back to The Trusted Pharmacist. I'm your host, Steve Hoffart. And today I've got a guest that has come down the traditional road, but has learned that functional medicine is really the root cause of a lot of our issues. Joining me today is Elise Clark. She's a nurse practitioner with a background in everything from critical care to endocrinology. And now she's using functional medicine to help people balance hormones, fix gut health, and feel like themselves. So Elise, thanks for joining me.
Yeah, thank you for having me. This is fun.
Awesome. So just kind of jumping in, like, I know as a nurse practitioner or a healthcare provider, especially in the functional world, you get asked every day the same questions over and over and over. What's the one big myth today? If you're like, hey, I just want to stop this right now. Let's get the truth out there about this. What is that one thing you'd want to kind of debunk?
Oh, there's probably a few, but I think the top one will always be that hormones do not cause cancer. And I would preach that from the mountaintops if I was able to, because it is so clear in the data now that it doesn't. And we are just having to work, fight tooth and nail to convince patients and other providers that that was based on faulty data, not statistically significant, poorly done studies. And so I think that would be the number one thing I would say. And also caveat to that, kind of adding on, is that if you're on hormone replacement therapy and you happen to get cancer, your outcomes are significantly better. So if anything, we're going to benefit from taking hormones as opposed to giving ourselves cancer.
No, that's great. And I'm like you as a practitioner. I'm grateful for the sounding boards that are out there now about getting the information out, because you're right. We've had we that have been doing this for a while, really had to bang our head against a lot of media driven type stuff. It's cancer. And you said something too that I find interesting. Like, so many of these studies, quote unquote, in the past, it talks about progestins and never progesterone. And that's to me, the really bad thing that goes on. How do you find yourself as a nurse practitioner working with patients to get that message? Like, hey, it's hard to even ask your patient to read deeper into these studies. How do you get your patients to kind of understand that aspect when it's kind of flashing lights everywhere, cancer and all this other stuff?
There's some good resources of people who do social media, thankfully, because I'm not one of them. I like to make a presence just so people know I'm real, but it's not my thing. So I think that in our day and age, it is really nice to point patients to some people that are very big on social media and break it down really clearly. But in my day-to-day patient interactions, there's a book called Estrogen Matters that's really a great resource that I give my patients, especially when they're menopausal, postmenopausal, and we're doing estrogen. But I break it down in very simple terms and help people realize that progestin and these long-winded versions of estrogen that are on birth control pills or Premarin, that is an older used hormone replacement therapy product. If it doesn't say estradiol on it, it's a synthetic form. And if it says estradiol, that's real estrogen. And a lot of people don't know that there's even a difference. We just, in the medical community, use the words estrogen and progesterone synonymously between different types. And so that's the first thing I try to point out to people, is they are not all the same. And we can't really use the term estrogen and progesterone to describe all the different kinds. So I'd like to make that distinction. Progesterone and estradiol are the safe hormones, whereas progestin, and again, these really long-winded versions of estrogen, they're not the real thing. So a lot of patients just don't even know that basic fact. So it's really interesting and rewarding to tell people what's in your birth control pill is not hormone replacement therapy.
No, and the words are so important because I saw a healthcare provider the other day going on this same thing. Hey, hormones are safe now. We need to be on them. Look, this is what I do for myself. And the craziest thing she mentioned, what she was taking was a progestin. And I'm like, oh my God, and that's the battle that we fight. It really is kind of struggle. So on those same lines, let's talk about, like we talked about, I think the data is really there to say hormones done right in the right forms, dosed the right way, monitored the right way, really decrease our cancer risk. And that's even for things like breast cancer, for instance, which in the past is like, oh, it's not that. But with that said, let's talk about, in your mind, is it ever really too late for somebody to start hormones? Is there a better time to start hormones? What's your take on that?
Yeah. If we're talking about for menopausal women, the ideal time frame to get the maximum long-term benefit would be to start it within 10 years of your last period. And that's going to be to maximize the benefit of reduced heart disease risk specifically, but you can still get benefits. So you're never too old. I mean, there are certain health conditions we have to be cautious with hormone replacement, but you're never too old to do hormones. Sometimes we have to choose the route a little more carefully, depending on your health history. But I have women who've come to me in their 60s and we start them on it for the very first time. It is better to start closer to that last period just for more of the disease prevention benefits, like I said, but you will still get those benefits and no matter what age you start them. So the main reason I love hormones is, one, I am a woman. I have a lot of them. And so I know what it's like when they're not balanced. So I want people to feel good, but we're living a lot longer than we ever have. And so, unfortunately, I watch like my grandparents' generation and they lived a long time, but they didn't really live well. And so if I'm going to live to be 86, 90, 95, like my grandparents, I want to be as functional and as healthy as possible. And estrogen and progesterone and testosterone can really reduce your risk of all the big stuff: Alzheimer's and dementia, heart disease, osteoporosis, and just keep you more mobile, keep muscle tone up. So that's a big thing, is we lose our balance and our muscle tone. So we fall, and then a lot of us die of hip fracture results. So it's not great. So I always tell my patients, I want to do this so you feel good, but my main motivation is for you to live well for a long time.
I love that. And that's so true, because traditional medicine's great at keeping our organs functioning. But if our body can't move and we don't have a good brain, it's kind of pointless to live longer. And I'm like you, I want to live to my 80s and 90s, but it's like you want to be healthy. And I think you've seen it too. Those patients that you've had on hormone therapy these years, they are getting, it's 60s, 70s, 80s. And these people are pretty darn functional. Like,
oh yeah.
Sometimes I'm in my 50s and I'm like, I wish I was that good. So I hear you on that.
Well, I won't age my mother by telling you her age, but I have a sister in her 40s, if that tells you anything. And we're all right around that age. So my mom has to be of a certain age and she can run circles around me.
No, that's so awesome.
And the hormones are a big reason why.
Oh yeah, no doubt about it. I think that's one big piece of the puzzle. There's a lot of things, but hormones play a lot. One thing I think that's gotten a lot of notoriety, and no offense, when I was at pharmacy school, I don't think this part of a woman's life got maybe one chapter and one lecture in one day, is perimenopause.
Yeah.
And I think the good thing is we know so much about the benefit of hormones at menopause, but that perimenopausal year, and for the challenges, it is so different for most women nowadays, and how they slide into perimenopause and what that looks like. What's your take on perimenopause and your treatment like philosophies to make sure that women has a nice transition from perimenopause into menopause?
Yeah, so perimenopause is a really hot topic right now, and it's pretty relevant to me and my friends because we're all getting there. So I get a lot of questions, but it's also one of my favorite things to treat because it's more ignored in the traditional setting. And the problem with it is there's not really a defined criteria. In medicine, we like to be able to say, okay, if we're going to diagnose you with hypothyroid, we want to see a TSH of this, a T4 of this, a T3 of this. There's really no lab values that correlate with perimenopause, to be honest. It's really more a collection of symptoms. And it really mimics menopausal symptoms, but you're younger and still having a period. So it can look like worsening PMS. A lot of people complain of that first. It's like that period leading up to their actual period of So 3 to, 7 days, a lot of people will notice like they're really irritable. They're super moody. They get hot flashes. They get night sweat. And then when they start their periods, they're heavier, they're more painful. So you start to see these results of hormone shifts, not necessarily hormone depletion. So what happens first is because we're not ovulating as we get older as efficiently or as often. So your progesterone level doesn't get as high. And we love progesterone because it is very calming. It converts into allopregnanolone, which works on the GABA receptors in our brain, and GABA makes us feel really chill and really calm. And so without that progesterone getting as high, we're noticing those mood effects. Our periods can be heavier as a result. Sleep can be disturbed. So you are kind of experiencing the beginning of menopause without a defined lab criteria. So I hear this all the time. Women will suspect that's what's going on. They'll go to their doctor, maybe a more traditional OB, and they check their labs and they're still making estrogen and progesterone, and their brain signals, FSH and LH, aren't high, which is an indicator of menopause. So their doctors just tell them like, oh, you're okay. We all go through this. We'll start giving you hormones when you're in menopause. And I don't like that answer personally for myself. So my philosophy on treating perimenopause is, get the foundational things in order: stress, sleep, nutrition, gut, all the things that I call the foundations. But on top of that, I always like to do some hormone work. If someone's having symptoms of progesterone withdrawal, or even just symptoms right before their period of that dip, then I like to use progesterone by itself. And I'll do progesterone for years and years leading up to menopause. And then when their ovaries really start to shut down estrogen production, we add in the estrogen. And during that period, depending on goals and symptoms, I'll also do testosterone quite a bit. And I think probably, in your mind goes without saying, we have to make sure that the thyroid gland is really happy too, because oftentimes it's not like a true menopause defined criteria that happens with the thyroid, but as our ovarian hormones and adrenal hormones start to slow down, our thyroid takes a hit. So we have to make sure that that gland is functioning well too.
And that's the true definition of functional health. There's all these functions going on that we've got to keep in balance. And if we don't, we're going to have problems. And you're right, for women, unfortunately, during menopause, there's a lot of functions that are changing. And I think that's one of the challenges. You mentioned about progesterone, the importance of perimenopause. And I think that sometimes gets missed, especially on the traditional side, because I think that has a lot to do with it. But let's go back even younger. Let's talk about females. I've seen your passion on this on your social media stuff. You said you don't do much, but I have seen this on that one for you. And that's your kind of wanting to really educate women on the challenges and things that can happen with birth control pills. Give me your take on that. I think this is one that's really missed because these things are given out, like candy. There's many states now where even pharmacists have the ability to dispense birth control pills without even a doctor. It's the craziest thing because I understand the importance of it, but I don't think we know the healthcare risk. I'd love to get your take on that.
Yeah. First I want to say that I'm not against birth control at all, because I do think that it has given us as women this great opportunity to decide when we want to have children and our sexual health and all that. So I do think it was a fantastic invention. I think that the way that we should be using it, though, is for the shortest duration possible for what's needed. So a lot of times, and this was my generation, when birth control got super popular, I was a teenager. And so for acne, for irregular bleeding, for any reason, it was like we were all put on birth control pills. And what happens is when you're given these fake hormones, so fake progestin, fake estrogen, it doesn't do the same thing as the bioidentical versions, which I was talking about that we use with hormone replacement. It actually tricks your pituitary gland, and your pituitary gland stops signaling your ovaries completely. And that's how it works for birth control, because if your ovaries are essentially shut down and you're not making estrogen or progesterone, you're not going to ovulate. There's no chance of getting pregnant. That part of it is wonderful because you can control that aspect of your life. But I think the missing piece is educating women on low estrogen and progesterone in the long run can cause a lot of side effects and symptoms. So even in my younger patients in their 20s, I'll see vaginal dryness, low libido, high cholesterol, high C-reactive proteins, because we're not just not ovulating and preventing pregnancy, we're really shutting down natural hormone production, which is incredibly important for overall health. And I will say, women that come see me who've been on birth controls for a long time, the most common things I see in their labs would be a high C-reactive protein, which is an inflammatory marker. And it has been well documented that these synthetic hormones can cause a high CRP, which increases your risk of a lot of things, but in particular, things like heart disease. And if it stays high long term, that's not good for any of us. So I see that a lot. I see high cholesterol because our body actually uses cholesterol to form our hormones. So if we're not making hormones out of this cholesterol, what's it left to do? And there's other, I think, processes that go along with why it's elevated, but that's a very common thing that I see. And then some of my patients will actually end up with kind of weight issues from it because estrogen, progesterone, and testosterone are so important for our metabolic health. So even things like weight fluctuations, fluid retention, I'll often see that. So I, again, am a fan of them when we need them. But if we're using it as a Band-Aid long-term for more serious issues like PCOS or endometriosis, again, shortest length possible while we fix the underlying issues. But I do also see, and I know people argue about this, and I know that there still needs to be research on it, but a lot of my patients have had a harder time getting pregnant after being on the birth control pill for, I'm talking not short term, I mean like 15, 20 years. And they've never had a chance to let their ovaries actually work. And so I definitely think that can play a role somewhat too. And I have plenty of friends who anecdotally would say that was part of their issue with getting pregnant. So again, I don't want to sound like a hater of it because I do think there's some benefits, and sometimes in certain patient populations, it's the right answer, but I always want to know, why are we using it? And if it's just for pregnancy prevention and we need to get your hormones back to normal, what else can we do?
That's a great call, and a couple takes from there. That's a great list of some of the negative side effects that we see. And you're right, some can stop after the birth control, but some of them don't. The other thing I know that's common too is it increases sex hormone binding globulin like the rest of your life, which is one of those other reasons why your body can make all these hormones, but they don't work because they're bound up. And like you mentioned, that's one of my challenges with prescription drugs is when we block natural things the body does, there's consequences. Yeah. Well, birth control pill blocks what the hormones do. And we've already talked about the importance of hormones and how they're so important in overall health. And you're right, it does create challenges. And I feel like so many women who are not on them or that are on them aren't really given that information up front and then realize this out. They get off of it in their late 20s or 30s and want to have a child. And they're like, oh my gosh, like I didn't know this. I wish somebody would have told me.
Well, and I think that's twofold too. It's like, you could just have some stunted ability for your body to get back in its rhythm and start ovulating because it just hasn't in so long. And then the other side of that I've seen is the birth control pill suppressed PCOS for so long that they really didn't know that they had it. And then they come off trying to have kids. And then now they're dealing with PCOS and have to get that under control in other ways before they can pursue their goals of fertility. And so it just kind of adds time and complication when you're younger and don't need the actual pregnancy prevention. We could have hopefully worked on some of that prior to whatever goals you have with fertility.
And that's a great call out. If these are used for hormone imbalance issues, let's address those root cause issues and let's not, I've seen some ladies as in their 20s that need progesterone just because they've got issues and some of those type things with PCOS and all. You fix those things versus having to give a birth control that causes a whole host of other things. So that's a great call out right there. We talked earlier, and this is common as a compounding pharmacist. I get asked a lot about this is ladies who are postpartum. You've got some background in this and struggle after having that child with hormone irregularities and different things like this. Tell me your kind of what you see for those ladies postpartum and then kind of what your treatment options are that you like to use.
Well, having been postpartum twice, I can personally relate. It's a crazy time. And I thought I was prepared and I was not. So what happens if you're breastfeeding, I'm going to speak to that a little bit more specifically because that really causes your hormones to stay down for a while. So after your baby, your estrogen and progesterone are super high. I'm talking like your progesterone can get into the 400s. And when you're ovulating, it typically tops out at like a 20. So you're really high on these feel-good hormones while you're pregnant. I know we don't all feel good because we're also growing a giant human, but these hormones at high levels generally make us feel good. And so you go from that prior to delivery to postpartum. As soon as your placenta is out, your hormones drop. So you're basically thrown into a semi-menopause-like state whenever you're postpartum, because if you're breastfeeding, your prolactin is going to increase from that pituitary gland to cause breast milk production. But the prolactin is what shuts down your ovaries. So I like to think it's like the body's way of saying, hey, don't get pregnant yet, even though you can technically. But your ovaries do remain pretty shut down while you're breastfeeding until you start having those periods again, 6 months plus down the road. So you're in a little bit of a menopause-like state. And so you can experience hot flashes and night sweats and severe mood swings. And those are the two common ones that I hear. And that often leads into more serious mood disorders like postpartum anxiety and postpartum depression. So I don't deal with super complicated cases of that. That's what my friend Everest is for, because she does functional psych. But if there's mild cases of that, I'm going to, again, work on the foundational things, because if you're postpartum, we have to make sure that you're eating, sleeping when you can, managing those fight or flight hormones. But a big piece of it is initially, we can actually give you progesterone. And I took it immediately postpartum. We'd have to be a little careful on the dosing because some women's milk supply can go down if you get too high on it. So I typically stay fairly low. But progesterone, again, converts into that allopregnanolone, which helps the brain amplify GABA, which is the feel-good, calming hormone. So it can work wonders postpartum. And then you do avoid the need for other prescription medications that have more side effects. And we were talking about the really fancy one that you can get it requires an infusion. It's actually just allopregnanolone. It's really expensive and kind of complicated to do, and it works. But we can also give just the progesterone and let your body convert into that allopregnanolone and help you feel better. So my take on it is most of us don't eat enough when we're postpartum because we have such crazy schedules. So I really preach self-care, even though it's so hard to do in that initial postpartum period. But then also progesterone, if we're experiencing mood issues, can be huge and keep you from exposing your baby to other things that you might not want them to have through your breast milk supply. And again, I am all for women doing what they need to do to treat whatever they have going on. But there's things we can try before we get to those more intense medications.
Yeah. And that's so critical, because I see so many women that are given medications and the next thing you know, they're forced not to breastfeed because they're on that medication. And like, that's the part that just really kind of creates a lot of stress for me when, like you said, sometimes just something as simple replacing progesterone can be a big fix. Along that same line, we didn't really talk about this earlier, but just kind of curious, are you seeing more and more women have flares of like autoimmune conditions after pregnancy nowadays? Is that something you're seeing? I see that. What is your take on that?
I see a lot of autoimmune flares, particularly Hashimoto's, and then I'll see things like high CRPs and high ANAs that we can't really identify the root of. Now, again, I can't compare it to other generations necessarily because I've only worked with this one, but I do feel like it is very prevalent, and I don't have a comparison from 15 years ago or anything. But it is, if you look it up, it's so complicated because I really dove into this as a personal interest for a while. It's like, okay, what happens to your immune system when you're pregnant? And it's crazy because certain immune factors will be going up to help protect the baby and you and keep you well. And then other immune factors have to go down so you don't actually reject the baby. So our immune system, in my minimal understanding of these complicated matters, freaks out when we're pregnant. And so that's part of why we think that these postpartum autoimmune issues really start to creep up. And I work a lot with Hashimoto's, so that's kind of more my personal experience. Is I do see if someone has a thyroid issue, it often happens postpartum, and it often is Hashimoto's from that kind of pregnancy trigger. So yeah, the immune system's nuts. I wish I understood it better because it is so complicated.
No, you're exactly right. So let me ask you one question, because you've mentioned Hashimoto's a few times. Especially for those ladies prior to pregnancy, I think it's so important to have that understood. And you mentioned, I've heard you talk before, a lot of times we're not looking for autoimmune conditions till later in life, but I really do think that's so important to be looking at those things while a female is younger, while they're going through hormones, so that it can actually, I think it'll make perimenopause easier, it'll make menopause easier, but even more importantly for the health of a pregnancy and a child. What is your kind of take on that? I'd love to get your thoughts on that. You're very knowledgeable about that. So.
Well, I have a little personal family background with it. My mom has Hashimoto's. I'm just going to give all of her information out here.
She's not going to be real happy when she listens to this one now. I'm joking.
She's a nurse. She does not care, I promise. And so I saw like firsthand, she went undiagnosed for a long time. Kind of saw firsthand how detrimental it can be to someone, how they feel, their quality of life. Thankfully, she never had major health issues as a result before she got diagnosed. But once she found out and not only corrected the thyroid replacement aspect of it, but addressed the autoimmune aspect, she felt significantly better. So I think from that experience, and then just getting into this and learning from a very knowledgeable doctor, I've always checked for Hashimoto's in every new patient. And then I will check for it periodically because, especially in women, it is more common to kind of sneak in from triggers like viruses. And I feel like I saw more of it after COVID. I don't have statistical data on that, but just anecdotal. And so I always check everyone for it at their initial appointment with me because it goes missed a lot.
No, that's a good call out. And I appreciate you bringing that up. I just think I like that you check it on all your new patients, because that's one of the first things I'll have when I see some patients and we'll ask about get thyroid numbers. And like you said, we get to TSH or something. I'm like, they've never checked your thyroid antibodies and you've got all these low thyroid issues. And yeah, it's kind of crazy
it's crazy to me. And I had a patient ask me yesterday who has Hashimoto. She's like, would there be any advantage of me seeing an endocrinologist too? And I was like, I would love for you to get another opinion if that's what you want, because I want everyone to get the knowledge they need. But I was like, I used to work for one. And all we told people was there's nothing you can do about this. It just explains why you need thyroid medication. And now I just cringe when I think about that.
You so nailed it. That's why everybody checks it, because it's like, okay, you have it. That's what, but they're like, no, on a functional medicine approach, there are so many things we can fix to take care of that, so it don't turn into the next autoimmune condition and whatever else. So that's really kind of cool. Well, this has been awesome. Thank you so much for your time today. If people want to learn more about you, Elise, where can they check out more information about you?
Yeah, so I try to be good about Instagram. It's my name, Elise Clark FNP, which stands for Family Nurse Practitioner. And then my website is eliseclarkhealth.com. And then I actually started another practice with my colleague Everest, who does functional psychiatry. And we have a functional medicine clinic together called Evergreen Functional. And we have some people that work with us with other specialties. So we love being able to pair patients with the right person, because I know a lot about what I'm passionate about, but there are certain things I don't quite have the knowledge on, and I am not too big to admit that. So we wanted to create a place where everyone could be seen with the right people. So either place, Evergreen Functional or Elise Clark Health, you can find me.
I think that's what makes functional medicine for me super awesome, especially working with practitioners like yourself. It's really a patchwork. We all kind of have our passions and those things that we're really good at. And functional medicine is really a patchwork. It's trying to sew up all those pieces and complete a complete picture so people can see that. And so that's really cool that you brought that out. I think that's really, really awesome. Well, I hope anybody, that's exactly right. Well, I hope anybody that listened to this today, if you found things you like, especially in terms of hormone health, birth control and all, please give us a like. Please share this with somebody you know that may find benefit. And like you said, Elise, thank you so much for joining me today.
Yeah, thank you. This was really fun. I appreciate your time.
Very cool. And then, like you said, until next time, keep seeking the truth about how the body works.